Yo, what's up? This is a podcast that does not have a name and it has one episode. And if we only have one episode, you better talk about something important, I guess, you know? So what we're actually talking about is unarmed crisis response. So basically what that means is responding to a crisis without arms. So not the police, not people with deadly weapons. And so a little history. Back in 1981, everyone's favorite Republican president, Ronald Reagan, cut funding to hospitals for mental health treatment. So that changed how people responded to mental health crises. So instead of there being ample um, resources through hospitals and mental health professionals available to deal with 911 or 911 type calls. Now they're actually calling the police, calling 911. So a police officer would be the first person to respond to that. Problem there is police are not trained to deal with these types of mental health crises. Um, a social worker probably would be, but in today's day and age, largely we do not have networks set up to have people responding to these crises that are not using deadly force. And so that kind of becomes an issue where a police responds to someone and it's clearly a mental health issue, but the person who is not trained to see it that way sees it as a threat. And we've had several examples in the media of people being killed, unfortunately. Um, and while it's difficult to say this is directly due to a lack of training, but it seems to be kind of obvious, especially to people like us who are social workers. So um, we have some background, we have some proposals that we want to give to address this. So yeah, I'll pass it off to you guys.
Thanks, Bryan. There are a few crisis response team models that have been implemented and tried out in the United States over many years. I would say that they really vary in law enforcement involvement in a given crisis situation. So, for example, one particular model only deploys specially trained police officers, so it's all police, while others pair police officers with mental health clinicians. But just for clarity's sake, we will be focusing on one specific crisis response model, which is called mobile crisis teams. So, in mobile crisis teams, community based mental health professionals are really the ones that intervene in a given mental health crisis. So, usually, what happens is that local governments contract with a mental health agency to provide mental health services in a intense crisis moment. So, what the mental health professionals do is that they do an assessment of the individual experiencing the crisis. They try to intervene and de-escalate in the moment. And then what's really important and sort of a unique piece of the mobile crisis teams model is that they refer them to services. Um, and they actually follow up with the individual even after the incident, just to make sure that they're okay and that they're following their treatment plan. So with mobile crisis response teams, it's not just in the moment, but after intervention, it's follow up. And mental health clinicians are obviously really well trained to do that. So what's unique about this particular model is that it's the lack of law enforcement intervention. Although police can be on hand to intervene if needed, but generally speaking, it's really the role of the mental health clinicians, and law enforcement is really hands off. So
Yeah, I was wondering, like,
yeah,
is this something where like 911 would be called still and it would be redirected by the dispatch, or is this like a separate number people are calling?
I local governments have a lot of say in how they want to structure it. I know that mental health agencies have their own like line that on call line that they can call. That's a pretty that is an existing model. Yeah, I would say like it could be both. But the real like big piece is like no police officers um, that come to the scene. It is mostly implemented at that local level. So local governments have a lot of freedom. Um,
kind
but
of
yeah,
whatever works for their infrastructure.
absolutely. Yeah. And
Gotcha.
it's localized at the moment.
And I think, Liz, you have some information on more detailed on some of the models that are currently being used.
Yes, I do. I'm not sure if Keegan, you want to continue talking about a couple of things in Michigan at the moment, or if I should just jump right in.
Yeah, no, no worries. Yeah, you can get into the models, and then we'll go back to the policy side of it because it's good to have some examples that we can pull from, so folks have a good idea, more of a grounding of what how these teams operate.
Awesome, sounds good. So we're going to jump into real world examples, which include Cahoots in Eugene, Oregon, Star in Denver, Colorado, and Be Heard in New York City. So in Eugene, they use Cahoots, which is known as the Crisis Assistance Helping Out on the Streets. This program has been a cornerstone of the community for nearly 3 decades. Cahoots is a groundbreaking partnership between the Whitebird Clinic and the city of Eugene, fielding a remarkable range of calls through their mobile crisis intervention units. Cahoots teams are often the first contact for those in need, acting as an alternative and compassionate response to situations that don't require a traditional law enforcement presence. Eugene isn't alone in this approach. Denver uses the STAR program, or the Support Team Assisted Response. They use calls on substance use disorders and mental health distress without uniformed officers, and instead send out behavioral health clinicians and paramedics who compromise with civilians, and they typically respond with to low risk situations where the safety concerns are minimal. And kind of going back to what Bryan was asking, what they can call. So Denver, they can call 911 operators, and then the operators will dispatch the STAR teams as part of the city's emergency response. So they kind of work hand in hand with the pre-existing system. And lastly, in New York, their Be Heard program. Be Heard stands for the Behavioral Health Emergency Assistance Response Division, and it is a part of a broader commitment to reevaluating mental health crises and public issues instead of viewing them as a public safety issue. So they use physical and mental health expertise and their experience in crisis response to de-escalate emergency situations and basically provide immediate care for those who need it. So all in all, these cases highlight a crucial point, and that is that communities are actively seeking alternatives um, in order to respond to these types of emergency calls. So they deploy specialized unarmed responders that are skilled in de-escalation and crisis management. Programs like Kahoot Star and Be Heard are the new methods to keep citizens safe while addressing their needs with care and compassion.
I mean, so that all sounds really good, and it sounds like it's something that could work. I'm just thinking in my head, like, what are people going to be saying who there's always going to be detractors from things like this. And I'm just thinking of counter arguments to this that people would make. Like, is it maybe a good idea to let basically groups of unarmed civilians respond to potentially violent individuals? Um, and I see the potential for some people to think that, okay, there are violent individuals out there, the police aren't able to do anything about it. And so I would hate to see like a rise in like vigilantes out there trying to respond to people because they know that they see someone who they think is acting like erratic, and they know the police aren't going to be called, and so they're going to respond, take matters in their own hands. Now, I'm not saying that that would happen. I'm just saying I could see some people maybe getting a little bit over eager. Um, so I think that, those are just things to keep in mind.
Absolutely.
But that being said, what would be our actual policy proposal?
Yeah, thank you. So just for some context, in terms of traction that these mobile crisis response teams have gotten, it's mostly at the city municipal level. 14 of the 20 most populous cities in the US have implemented some kind of non-police crisis response team. And in the state of Michigan, where we're based in, a Senate Bill 637, was signed into law in late 2021. So Michigan is sort of a good example where they have a grant program for local governments to implement community-based mobile crisis intervention teams. So local governments in the state can apply for funding to sort of set their own teams up. And this is done by the Michigan Department of Health and Human Services. So it's a state level initiative. And what we're basically proposing is to really put this state system at the federal level. It was a mobile crisis response team grant funding was proposed last year, but it really didn't get anywhere. It was just referred to committee in the House of Representatives. So it hasn't gotten a lot of traction, maybe because of the detractors that the detracting factors that Bryan clearly stated out. But we think it's worthy to go back to the federal government to propose this again on a national scale. So we propose just a federal scale up of what Michigan has done with their grant program. So we propose that the federal government designate a pot of funding to fund, states, territories, or even tribal-wide teams in a policy kind of similar to what was called the 911 Community Crisis Responders Act of 2023 that was proposed last year, but because of the potential counter arguments and detractions there, our proposal does have some specific guidelines. So, for example, if states decline to apply for funding, we would allow cities and municipalities to apply. And that way there will be enough programs to assess effectiveness, because research and evaluation is really important to make sure that these initiatives are effective. If budgetarily possible within the federal government, this funding shouldn't be competitive. So anyone that applies and follows the guidelines should get funding to set this up. We believe it should be as widespread as possible to ensure safety for as many Americans as possible. So sort of like in Michigan's model, any states or governments that do receive the funding, for the most part, can structure their programs however they want, but we do have a few guidelines. For example, programs should not partner with law enforcement in any way, just to ensure that citizens feel safe and cared for. I've seen some data where even the presence of police officers that are either well-trained and have compassion can still not help de-escalate the situation and can still lead to really bad mental health outcomes. So there's that guideline that we really don't want law enforcement involvement.
I think
Another guy.
Oh,
Yeah,
sorry.
yeah.
I was just thinking too, like it just seems like one of those things where there's gonna be difficulties. For instance, it's gonna be hard to tell what constitutes a mental health crisis unless you're actually there on scene and you have someone trained to determine that. But
Yes.
until we try and actually implement some of this stuff, and we're not talking about mandating anything, we're talking about making it
Absolutely.
available for people. So the more we do this and the more we make it a regular thing, that's a great way to work out the kinks. That's as good a way as any as I could think of.
Absolutely. I absolutely agree with you. We have to implement it and evaluate to see, if it's enough, if it is effective on a scale. So I know that there are some common concerns about 911 dispatchers not knowing whether to divert the call to a crisis response team. And we will require that states provide training to those individuals just to make sure that they divert to the right place, since they're most likely not mental health clinicians. So they definitely will need some training on that. And one common detractor that I've seen is that, like, oh, you're just go and employ just vigilantes, just random people off the street,
Right.
And not trained professionals. So we will have a guideline that, states can have regular civilians, but they have to train under a mental health clinician for at least a year so they can get the proper on-site training that they need. We take this very seriously. We want the proper training for folks. So if someone's not a mental health clinician and wants to join a state program, that they would need to train under a mental health clinician for at least a year, just to provide that foundation. So We hope that this can work at the federal level. Again, these guidelines will hopefully help make it smoother. But like Bryan said, it's really crucial to try it out and work out the kinks if there's any unintended consequences. So that was what we propose. We hope hope lawmakers at the federal level see the potential here.
Yep. So I think this was informative. I think it's like a good entry level conversation into the subject. I don't have anything else to add unless one of you guys do.
Nope. It seems to be a very effective model at the local level. And I'm just super curious to see how it will scale up, because there's been so many examples locally. So I'm excited to see where this model takes us into the future.
Alrighty, well, thank you guys for listening, and this will be the first and final episode of this podcast, so don't look for it anywhere. It won't be streaming, and thank you.